Okay, today I'll be discussing on microvascular complications of diabetes. So diabetes mellitus is a chronic disease that occurs when the body fails to produce insulin, as in the case of type 1 diabetes, or in case of type 2 diabetes, there's insulin resistance despite adequate production of insulin by the pancreas, so that the body will not utilize the insulin adequately. So the prevalence of diabetes is increasing and it's associated with both acute and chronic complication, and it has high morbidity and mortality. So complications of diabetes can be either acute or chronic. The acute one can be classified as diabetic ketoacidosis, DKA, hyperglycemic hyperosmolar state, HHS, or hypoglycemia. Our main focus will be on microvascular complication, the chronic complication. So microvascular complication affect the small vessels in the body, so it can affect either the eyes, the kidneys, or the nerves, what we call is neuropathy. So macrovascular, it affects the large vessels, can cause damage to the heart, leading to coronary artery disease, peripheral arterial disease, and also the brain, causing cerebrovascular accident. So as you can see from the picture, diabetes affects multiple organs in the body. So in the eyes, in addition to retinopathy, it also causes glaucoma, cataract, and other problems. So in the renal or the kidneys, it's the commonest cause of end-stage renal disease. In the peripheral nerves, it causes loss of protective sensation, leading to minor foot injury, later on gangrene and amputation. In the large vessels, it causes stroke in the brain, coronary artery disease in the heart, and also peripheral arterial disease in the legs. The first microvascular complication that diabetes causes or diabetes affects is the eyes. We call it diabetic retinopathy. So it's the most common cause of blindness in working age adult groups. It's strongly associated with duration of diabetes as well as poor glycemic control. Clinically, most patients are asymptomatic, and in the late stage they might present with decreased visual acuity, not corrected with refraction. They can have curtain falling with the vitreous hemorrhage, and with resolution of this hemorrhage they can have floaters. So diabetic retinopathy also worsens with pregnancy, probably with the pre-existing eye disease, and also intensive glycemic control. And also intensive glycemic control in the first year of treatment, especially those having poor glycemic control at baseline, they have worsening of diabetic retinopathy, even though this intensive glycemic control has been beneficial in the long-term outcome. So it can be classified into earlier stage called non-proliferative, and it's marked by cotton wool spot or ischemia, hemorrhage, and as well as microaneurysms. In the late stage, it can be proliferative stage. Here there are new vessel formation or neovascularization, and as a result, fibrosis, traction, and retinal detachment can occur. So treatment is addressing the risk factors. So good glycemic control, individualization is appropriate, and hemoglobin A1C less than 7 generally is recommended, and good blood pressure control, blood pressure of less than 130 by 80 mm mercury has shown to reduce the progression of diabetic retinopathy, and avoiding smoking, managing hyperlipidemia, as well as treating the underlying cause like laser photocoagulation or pan-retinal photocoagulation, especially in proliferative and severe non-proliferative types of eye disease, has shown to decrease rate of progression of diabetic retinopathy by at least 50%. So the other treatment is antivascular endothelial growth factor. These are medications, and vitreous surgery in case of vitreous hemorrhage. So retinopathy, diabetic retinopathy, can be seen either by retinal photography or by ophthalmologist using dilated funduscopy or ophthalmoscopy. So this is a picture showing the comparison between normal retina and diabetic retinopathy. As you can see, there are cotton wool spots as a result of ischemia, hemorrhage, microaneurysms, as well as new vessel formation or neovascularization. The other organs to be affected by diabetes are the kidneys. We call it diabetic nephropathy or diabetic kidney disease. So it's the leading cause of end-stage renal disease, and about 20 to 40% of diabetic patients end up in diabetic nephropathy. So it's common in type 1 diabetes, But since the prevalence of type 2 diabetes is higher, most patients with end-stage renal disease and diabetes have type 2 diabetes. So progression is more common in type 1 diabetes. The reason for this is most type 2 diabetes patients, they die due to cardiovascular cause even before they develop end-stage kidney disease. So the commonest cause of death in these patients is cardiovascular disease. Clinically, most patients are asymptomatic. They have no symptom until late stage, but in later stage they have symptoms of fluid overload like hypertension, decreased urine output, body swelling, edema, and as a result of CKD late stage, they can develop complications like anemia, hypocalcemia, and on urine analysis, we can find proteinuria or albuminuria. Treatment is addressing the underlying causes: glycemic control, blood pressure control. At least a target of less than 130 by 80 millimeter mercury has shown to delay the progression of diabetic nephropathy and to end-stage renal disease. The other is we should avoid smoking, manage hyperlipidemia, and drugs like angiotensin converting enzyme inhibitors or receptor blockers or the AC inhibitors or ARBs have shown to delay the progression of diabetic nephropathy and progression to end-stage kidney disease. This is due to decreased intraglomerular pressure by these drugs, and they reduce hyperfiltration, hyperalbuminuria, and other causes. So they also manage hypertension. So they are promising agents, or they have been used like for many years, and they have shown to delay the progression of nephropathy. And in the end-stage kidney disease, we can either dialysis or renal transplant. The other organ or the other disease to be affected is the nerves, or we call it diabetic neuropathy. So it's a diagnosis of exclusion, meaning all other causes of neuropathy in diabetes patients like vitamin B12 deficiency, vasculitis, hypothyroidism, and other causes should be ruled out before we conclude the diagnosis as diabetic neuropathy, because these conditions are also common in diabetes patients. So it could affect either the peripheral nerves or the autonomic nerves. And the peripheral nerves, usually patients have loss of sensation, loss of protective sensation of the feet. As a result, they are susceptible to minor trauma because they can't sense adequately, and there will be injury as a result, foot ulcer, gangrene, and amputation. Most patients, they are asymptomatic, okay? So some patients, they have painless neuropathy and some have painful neuropathy. So if they have pain, they present with burning, tingling, and numbness sensation. And those patients with autonomic neuropathy, they can have orthostatic hypotension, resting tachycardia, as well as hypoglycemia, which are also common cause of mortality in diabetes patients. Treatment, there is no specific treatment that targets the nerves, but we should control the pain to improve the quality of life of the patient, as well as address risk factors like good glycemic control, good blood pressure control, avoiding smoking, limiting alcohol intake, and also pain control. And we can use some approved drugs like pregabalin, gabapentin, duloxetine, and amitriptyline. So in general, it affects microvascular disease, affect the eyes, the kidneys, and the legs, resulting in blindness, albuminuria, end-stage renal disease, as well as foot ulcer and amputation. So since we said most patients are asymptomatic, what we should do to decrease our risk factor for microvascular complication is we should have a screening, appropriate screening. So in type 1 diabetes, screening is recommended at least 5 years after diagnosis, then annually. But in type 2 diabetes, since the complications are already present even before the diagnosis, so screening should be at the time of diagnosis and annually thereafter. And based on the complications, more frequent screening can be done. In pregnancy, so diabetic retinopathy progression is common, so screening before conception or at first trimester, then every trimester, at least the first year postpartum, we should have a screening, because this is the common time period for progression. So what we should do to decrease the risk of microvascular complication is to address the risk factors: good glycemic control, good pressure control, as we said, target of less than 130 by 80 millimeter mercury, avoiding smoking, managing hypercholesterolemia, and treating existing complications like Laser photocoagulation or pan-retinal coagulation for diabetic retinopathy has shown to decrease visual loss by 50%. AC inhibitors or ARBs to delay the progression of diabetic neuropathy, and even though there is no specific treatment for nerve, by controlling the pain will improve the quality of life of the patient.